Alrighty, today is day number 37. Day number 37. We got big things happening this week. In our sixth and final week of boot camp, we have superstars of cardiopulmonary wellness and rehabilitation. We have some dancing unicorns. We have some dancing Patricias, some dancing grannies. This is it. This is the big time, okay? You made it. It's a big show. Things are happening. Things are moving. Every day I see great things happening. I hear from people whose lives are getting better, and you're in the clique. So keep it coming. Let's keep doing this. And one step at a time, and one day at a time. And that's it. Have a great day, everybody. Have a great day. All right, so today's question of the day. People ask me all the time to explain what the differences are between COPD and pulmonary fibrosis. And the things that I talk about most often are COPD, IPF, and pulmonary hypertension, although this can be kind of thought of as broader categories, which are the obstructive diseases, the restrictive diseases, or the interstitial lung diseases, and pulmonary hypertension, which is a pulmonary vascular disease. So there are commonalities between these three diseases, even though the etiology amongst the three is different. And in a nutshell, when we talk about the obstructive diseases, we are talking about diseases where people have difficulty with exhalation, okay? They have difficulty with the expiratory phase of breathing. And what that means is that when they try to exhale air or expel air, there's actually a narrowing of the airways. And this can be caused by structural damage. This can be caused by collapse of the airways due to poor structural support. And it can also be due to bronchoconstriction, which is a narrowing of or a constriction of the smooth muscle on the inside of the airways. In addition, inflammation can cause that smooth muscle to thicken, further narrowing the lumen or the opening. And then finally, secretion clearance can also impact this and make this worse. So one of the ways that I describe this is, imagine that the ideal airway is a 4-lane highway, and we have this inflamed airway that has thickened smooth muscle, and that cuts it to 2 lanes. Okay, then we add some bronchoconstriction, and that cuts it to 1.5 lanes, and then we add mucus, and those are like double parked cars. So then what has to happen is the air has to work its way, through this sort of windy, snaky road. And then when people blow out, we get collapse of the alveoli, and we get airway collapse or airway narrowing or airway bronchospasm. All right, so that's the obstructive diseases. So because of this difficulty with expiration or the exhalation phase, what winds up happening is we often have an increase in the residual volume in the lung, meaning the amount of air that cannot get out. Now, we all have some residual volume, but this is typically going to be increased in people with COPD and other obstructive diseases. For people with interstitial lung disease and pulmonary fibrosis, the pathology is different and the etiology is different. And in these cases, these are what we call restrictive diseases, meaning that there are difficulties with the inhalation phase of breathing. And the thing is that in addition to not being able to expand the lungs due to this increased thickening of what we call the interstitium, or the structural lattice work that makes up the support system of the lungs, we have a problem with diffusion because of this scar tissue as well. So people have a difficult time breathing air in, okay? They have difficult time taking a deep breath, but they don't have a hard time blowing the air out. And in some cases, it's actually exaggerated. So as opposed to the obstructive patient who's going to have a larger lung that does not have an easy time blowing air out. These patients are going to have a smaller lung, okay, with an easy time blowing air out due to the increased resistance, and in fact almost an exaggeration of blowing air out. So these people will wind up with a smaller lung with much less residual volume, okay? The pulmonary hypertension patient is a little bit different in the sense that this is a pulmonary vascular issue where we get a thickening of the pulmonary vascular bed, we get an increase in pressure in the pulmonary circulation, all of which increase the workload on the right ventricle. And the right side of the heart is typically supposed to be the low pressure side of the heart, and it has the structural framework for low pressures. And when you have pulmonary hypertension, the workload on the right side of the heart is significantly increased, and as a result, the right side of the heart is put up against pressures that it's not used to, and we can lead to right-sided heart failure. In a nutshell, the number one symptom of all of these things is shortness of breath. Chest pain is another symptom of particularly pulmonary hypertension. But the thing is that once this precipitating symptom comes, whether it be shortness of breath or chest pain or something else, it's the response to those, in other words, the decrease in activity, the deconditioning of the muscles and all of the systems that do these different activities that actually make the situation much, 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 much worse. And that's the whole idea behind Ultimate Pulmonary Wellness and our exercise programs, which is to prevent the person from making changes that are going to precipitate not just the disease itself, but the symptoms of the disease. So in other words, typically people get short of breath at high levels of activity. At the beginning, it may be stair climbing. Then people stop stair climbing. They find ways to avoid the stairs. All of the muscles and the systems that you use to do stair climbing get weaker. They become less efficient. They don't use oxygen as well. And then you get short of breath at lower levels of activity. That can happen with COPD. That can happen with pulmonary fibrosis. That can happen with pulmonary hypertension. And it does. Then you start to get short of breath at lower levels of activity. Things like walking uphill. Things like walking quickly. And you avoid those and so on and so forth. So up at the top, we have stair climbing, we have walking up a steep hill, we have walking up a moderate hill, walking up a mild hill, and walking quickly, okay? And there are ways that you can modify those and change those, okay? And eliminate those even, and have your lifestyle be changed, but still be able to do most of the things in your life. If people decondition enough, there's gonna come a point where it starts to affect things like getting dressed, taking a shower, even brushing your teeth or shaving, preparing your own food, doing your own shopping, etc., etc. And so the key is we want to stop this cycle way up at the top when people are only short of breath, at the highest levels of activity. We don't want to continue this progressive decline. And, one of the things that is disappointing to me is that there is still people will write things about these various conditions and they'll say these are progressive diseases, in which case your symptoms will continue to get worse until you die, okay? And I would add the caveat, if you do nothing about it. If you do nothing about it, meaning if you go home and you sit and do nothing and wait to die, then by all means, you will get worse and until you die. But if you start taking your medications properly, if you find out the best way to take them, the best order, the best techniques, add the exercise, eat better, support your body with great nutrition and great supplementation, manage your stress and anxiety, okay? Quiet that sympathetic nervous system down, and then take every step possible to prevent infection at all costs, okay? Then I believe that you have the ability to significantly curtail this prediction that things will just continue to get worse, and then that's the end, okay? Stick with the people who feel they can do something for you. When I hear doctors say things to patients like, there's nothing I could do for you, it's you're at the end of your rope, or you're at end stage, or it's only going to get worse from here. That's the cue. Switch doctors. Find somebody who believes there are things you could do, and not just from a medicinal approach. You may be maximally medically managed, or you may be maximized medically, meaning from a pharmaceutical approach, or you may be maximized medically, meaning from a pharmaceutical approach. But if you're not taking those medications properly, if you're not exercising regularly and vigorously, if you're not watching what you eat, if you're not managing your stress, anxiety, and depression through meditation, and if you're not taking steps to prevent infection, then by all means, you are not doing the things to keep yourself at the top of your game, okay? But for those who do, let's put a halt to progression, and let's work on regression and getting you back to doing the things that you want to be doing, okay? Have a great day, everybody. Have a great day. Yes, we can.